Hello everyone, we are happy to be coming to you on Rare Disease Day here from the new David H. Koch Center for Cancer Care at the Memorial Sloan Kettering Cancer Center. We're going to be talking about some very important topics today, but I want to tell you a little bit about the facility first. This new center houses the Hematology and Oncology Division of MSK, and with us to discuss peripheral T-cell lymphoma today is one of MSK's oncologists who focuses on lymphoma and is a member of the LRF's Scientific Advisory Board. He is also joined by two of the foundation's ambassadors who will be here sharing their own stories and their own journey dealing with lymphoma with us. So first, let me introduce Dr. Stephen Horowitz. Doctor, thank you so much for being with us today.
Thank you, my pleasure.
For those people who are watching at home, can you explain to them who might not have an idea of what lymphoma is exactly what we're talking about?
Sure. So lymphoma is a cancer of a kind of white blood cell called a lymphocyte. We have different white blood cells in our body, and if one of those cells becomes a cancer, a lymphocyte becomes a cancer, we call that a lymphoma. There's many different kinds of normal lymphocytes, and there's many, many different kinds of lymphoma.
So today we're going to be talking about specifically peripheral T-cell lymphoma. So for those who might not be familiar, what specifically is that type?
So peripheral T-cell lymphoma describes a group of cancers that come from T cells. Our normal lymphocytes are called B cells, T cells, or NK cells. And if a normal T cell becomes a cancer, we call that a T cell lymphoma. If it's what we call a mature T cell or not a primary bone marrow derived T cell, we call that a peripheral T cell. And then that describes a group of cancers called peripheral T cell lymphoma.
Now, my understanding is that peripheral T cell lymphoma, or PTCL, which we'll refer to it here on out, is an aggressive form of lymphoma. So what does that mean in terms of lymphoma?
So generally when we say aggressive, we mean that the growth rate is relatively fast. Just like a rough estimate is it grows over weeks to months, not years. Some lymphomas are very indolent or slow growing. They may grow over years or not change at all. Most subtypes of PTCL in most people, though there's a lot of variability, grow relatively quickly. The flip side to aggressive lymphomas is they're often treatable and potentially curable, and that kind of also informs the goals of treatment when we see someone with peripheral T-cell lymphoma.
So I want to bring in Rich Zawodowski here. Rich, thank you so much for being here today.
You're welcome.
You had a personal experience with PTCL, correct?
Correct.
Can you tell me a little bit about your experience and what your reaction was when you first heard that you were diagnosed?
Well, the experience started in 2007. I had, up to that point, 30 years of rheumatoid arthritis, and it was an autoimmune disease, and I was taking medications for it, and we think it may have triggered the onslaught of my peripheral T-cell. It manifested itself with skin problems, chills, fatigue, and some other elements, gastrointestinal problems, and I had to deal with it by going to doctors who covered those particular areas just to try to find out what it was. Now, this was when I was 65 years ago, or at a point when...
65 years old.
65 years old, yes.
He's very old.
And at that point...
We'll get to you in a second. No, I'm just kidding.
Sorry, this is formal. This is formal.
And at that point, it was, we didn't know what was going to happen. We had to find what was the problem. And one thing led to another. I met up with many doctors, oncologists. There were 3 or 4 that I had gone to for second and third and fourth opinions. And I had gone to a dermatologist, a gastroenterologist, a regular physician, just trying to understand what the heck was going on here. And they sent out biopsies of what they had gotten, and nothing came back affirmative as to what I had. Again, this was 11 and a half years ago, and so we went through many sources to try to find out what the pathology was, and ultimately we did get back to the National Institutes of Health, specifically the National Cancer Institute in Bethesda, Maryland, where a world-renowned pathologist who was one of the persons who identified most of these cancers up to that point, because up to this point there were about 80 known types of non-Hodgkin's and Hodgkin's lymphoma. And in that way, we didn't know what we were dealing with, but when she got the biopsies, she was able to identify it in a matter of a few days, where others had been taking 9-10 weeks to come up with some idea of what I had. But she was able to identify it, and from that point, it then led into whether or not I wanted to have a clinical research because the clinical research was available. I had not had any medications in my body. It was a stage 4 peripheral T-cell lymphoma. And in that regard, I had the option of going to a local doctor and having them give me what was the traditional treatments they were giving, but there was no standard treatment up to that point. Or go into a hospital environment with someone who could help me out, or go into a clinical research.
So let me ask you at this point, and we'll bring Chris in as well here. At what point, Chris is Rich's son, so what point did you tell your family about this? Are they going through all of this with you? And what was your memory of it like it as well, Chris?
Well, right now, right at the time we were going, the three of us were going through all this, all the doctor meetings, all of the analysis, all the internet work that was being done by my son. And my wife is an RN, and she was involved in the whole gathering of data and what we needed to do. We didn't even know about the Lymphoma Research Foundation nor any of the others at the time. We didn't know where to go, and this is the problem with, at the early stage of what do you do? But with their help, we sat down when we had collected all the data, and it was a number of months into this aggressive T-cell that we finally sat down one night and laid out all the things, and I said, well, we have the option of the clinical research, let's do it. My background was marketing director for research and development to the federal government in the energy, defense, and space community, and that's what I've been doing all my life. And in that regard, I had appreciation for R&D and knew research and development, and knew that it was something we needed to pursue. I'll let my son add more to it.
He seems very calm, cool, and collected talking about it today. Was that, how are you feeling? Was he like that?
Yeah, well, he was, so when he was diagnosed to finally figure out what it was, he was so sick, it was in his bone marrow, it was in his blood, it had metastasized in his several of his ribs, it had been eaten away at one of his legs, so he's wearing a boot because he couldn't walk. Well, I mean, he was knocking on death's door, and so he was very out of it at that point. Mom and I were the ones that really took charge and managed all the stuff, set up all the appointments, and really were trying to together make one collective brain to listen to everything, because you hear all of, when you're going through all of that, this is just a deluge of information coming at you. Had we stayed with the local doctor and what she was planning on doing, he probably wouldn't be here today, because the national lab that the biopsies were sent off to, 6 weeks later, they came back with a suspicious for diagnosis. It wasn't still even confirmed. Every day or every other day I was called.
A suspicious for? What do you mean when you say that?
It was suspicious for peripheral T-cell lymphoma. Gotcha. It wasn't a confirmed, this is peripheral T-cell lymphoma.
So how long was it that you were dealing with that? Like,
that was 6 weeks from the time they sent those biopsies off to the time we got that back. And I was calling every day or every other day just to the lab themselves, saying what's going on, why he's getting sicker and sicker. The local doctor was already scheduling for surgery to put Metaports in. Oh, we're going to start this chemo, not even knowing what it was yet. And one of the things, no matter what venue we're in, wherever we're talking, we always stress the importance of a good second opinion, especially in the lymphoma world now, with around 100 different subtypes of lymphoma out there, and every few years there's a few more. It seems like, are there more discovering more distinctions? We realize the importance of getting to an expert second opinion. So that's why we went to see all these other specialists, and also got his slides when we got them back and sent them over to NIH. And the doctor there, who was also on the board of the Lymphoma Research Foundation, I mean, they bring the best of the best into their orbit. She saw it, and 40 hours later said, oh, this is 100%, this is what this is. And oh, by the way, we have a clinical trial available. And we brought it back to the experts the specialists that we've now been seeing that knew lymphoma specifically. And they all said, hey, if it's your best chance of survival is to go into a clinical research study, to go into something. Since you're dealing with something aggressive, you need a more aggressive treatment. We have nothing standard and effective we can offer right now. And she, probably a great doctor for somebody that deals with just, not that any cancer I think is run of the mill, but something that she would see a lot of every week. Mm-hmm. This is a cancer, if she sees one of these every, a local community doctor, oncologist, probably how often would you say they would probably see a PTCL?
Probably 0 to 2 a year.
Yeah, so she, versus someone else, it's like, oh, we see this all the time, and we have a study just for this.
So let me bring Dr. Horowitz,
Yeah.
we'll come right
Yeah.
back in a second, Chris. But with that, since we're seeing at a local community hospital, I'm assuming, or a local oncologist, seeing this once or twice a year, how much do we know about PTCL? Do we know what causes it at this point?
So, a couple of questions there. So we know a lot more than we knew back then, and knowledge has increased tremendously. We know a lot about what's going on in the tumor cells. So we're learning more about what the problems are in the machinery of the cells, why they grow, why they're growing out of control, and things like that. We most of the time don't know why they happen. There's a couple of very rare subtypes that are caused by viruses, a couple maybe caused by some chronic immunosuppression, and maybe with a rheumatoid arthritis background that could have contributed. Most of them, though, we don't know why they developed, even if we understand what are the derangements in the cells.
So at this point, we heard about some of Rich's symptoms that he was dealing with. Are those common? Are there common symptoms of PTCL?
You know, the lymphocytes that become the cancer are active immune cells, so it's quite common that you get symptoms like you would with other settings of immune activation, which is basically infection or autoimmune disease. So you can get rashes, you can get swollen joints, you can get fevers, you can get sweats. All those things, like the immune system is sort of up and active, and we do see those a lot with people with T-cell lymphoma. I think when you have those symptoms for a while and it grows and progresses a little, then the symptoms can increase. And it's a too common story that it takes a while to get the diagnosis. And I think that's just a fact of things being rare. Pathologists don't see this every day. It's a pretty complicated diagnosis to make with confidence. So if they're not that experienced, they get clues, they get things that are suggestive, but it's hard for them to say this is definitely what it is and not some other inflammation that can kind of be mimicking a T-cell lymphoma.
Well, even his skin biopsy, got those slides after he'd already been in treatment, got to them, and they were able to see in the skin biopsy, oh, there's PTCL there, whereas the dermatologist and local person who had dealt with it thought it was a totally different rash and didn't realize that's what it was. So we would have caught it 6 months earlier had they seen a lot of that or known what they were looking at.
So, Rich, when you actually then found out what the diagnosis was, I mean, how did that feel after all those months of not knowing?
Obviously, it's a relief in your mind that there's something that you can now chase. But when you have such a divergent possibilities out there, you just don't know what is on, and uncertainty just fills your mind, and you just feel really messed up in terms of what am I going to do? What do I do next?
Yeah.
So it brought a lot of relief knowing at least the direction we were going, as opposed to a ship that's going all over the place.
And Chris, how about for you? Because you said you were making phone calls 3 times a day.
It was at least 3 times a week. I was calling them saying, what's going on? Where's the diagnosis? Oh, well, and you get a different answer every week. Oh, well, it went down to another, first it went to the wrong department. Then it went to this thing. Oh, no, we need a second opinion. That was just, it was scary because when we started this and figured out it was cancer, he was already very sick. He had rashes. He was very tired. He was cold. Cancer was was everywhere in his body. So before we got a diagnosis, he was literally knocking on death's door. We didn't know if he'd be there in a few months to blow out his own birthday candles or celebrate another Christmas with us or be there for another Thanksgiving. Because we were seeing so many doctors and it was kind of juggling and playing patient advocate, and there was not time to really absorb it like there is now. Mom and I will sit now and talk about, geez, we really dodged a bullet back then. I know that the survival rate has increased a lot over the last decade, but still 12 years ago and where we are now, it was very scary to be like, the odds are not great, especially then with what they knew. So it was great to know when we hear what it was. Of course, then we find out, oh, geez, this is not a good one to have. But at least you can move forward. Like we were so busy. Just next what's tomorrow? Not worrying about what's 6 months from now. It's just what do we have to do tomorrow? What's the next step forward?
So, Doctor, we're talking about more than a decade ago at this point. Right. So what is the experience like now in terms of identifying PTCL? Are patients still laboring for a long time just trying to find out what it is that they have?
It can happen. I think that's a less common story now than it used to be, that it takes a really long time. But it does take a long time. With any of these, particularly the T-cell lymphomas, there's cancers of these white blood cells. Other things that cause white blood cells to grow and go other places, cause rash, are things like infection. And really differentiating what's a cancerous T-cell from a reactive or an inflamed or an activated T-cell is not so black and white. I think, it's not like the pathologist can do the test, oh, and that's a cancer, yes, and this is cancer, no. It's really a constellation of features. A lot of those tests are quicker now. A lot of times they'll recognize something earlier and do those tests earlier on, so it's less common that it takes weeks and weeks. But it is a complicated diagnosis to make confidently, particularly by a pathologist who doesn't see this all the time.
So once we have a diagnosis, I think I heard Rich say earlier that there is no standard of care for PTCL. Is that currently still the case?
I think it's fair to say the way I like to say it is there's no universally agreed upon standard of care. With combination chemotherapy, and we talked a little bit earlier, some intensifying approaches, some adding medicines to combination chemotherapy, there is a cure rate, meaning there is a percentage of people who will get better and have it never come back. So that if you're treating with curative intent, or if the goal is to get rid of this permanently, which it usually is, that is a standard approach. But exactly what the best recipe is, how much to give, how many cycles to give, that's still a little bit up in the air. We recently have some data adding a drug that targets CD30, which is common on certain subtypes of T-cell lymphoma. And in a pretty big study, we now know that if we add that to chemotherapy, more people are cured than if we don't. So for some of those diseases, that's mostly true with anaplastic large cell lymphoma, and a little bit for some of the other T-cell lymphomas, PTCLs that express CD30. That's probably getting pretty close to a worldwide standard. Still room for improvement to build upon, but it's kind of where we are now.
So then what's the practice then for a physician in that? If there is a little bit of variation still, how do they determine which route they're going to go down?
I mean, some of it's style, some of it's your take on the data, some of it's clinical trials. So I think those of us at big centers, we usually have a standard approach, which is somehow involving strong combinations of chemotherapy. Maybe the recipes are slightly different, but it's more like charcoal versus gray. It's not black and white. These are variations on a theme. And then many of us have, as we learn more about T-cell lymphomas, we learn that different subtypes, and there's almost 30 different subtypes of peripheral T-cell lymphoma, different subtypes may respond better to other different medications. So there's a number of studies going on adding some of those specifically targeted medicines often to a chemotherapy backbone to try to do better. And that may be different center to center.
When you say 30 different subtypes, I mean, that sounds like a lot to me.
It's a lot. Yeah.
It is.
Yeah.
Okay, so Rich, I mean, do you know what your subtype of PTCL was? Did they go that far, doctor, in identifying that?
The only thing that they gave you was, they told me it was stage 4 peripheral T-cell lymphoma NOS, which was not otherwise specified. So it was a catch-all phrase.
The waste bin of like it's
Yeah.
So that still exists. PTCL NOS, not otherwise specified, means it doesn't fit one of the otherwise specified. Over time, that group has gotten a little bit smaller. It's still probably the second most common subtype, but we're better at specifying other ones.
Okay.
And for PTCL NOS, there's probably a couple of different main groups in there. There is some sort of general approaches. So the knowledge is better, but it's not that different than what you went through in terms of how we treat these with chemotherapy.
Right.
So, go ahead, Chris, you want to
I
add
just wanted
something?
to jump back.
Please.
If we'll get to, but one word he used a few times that when we were going through this wasn't being used at all was cure. Everything was remission. Even at the Lymphoma Research Foundation, the national forum they would do, the educational forum they do annually, their Ask the Doctor events, breakout, anything we ever went to, it was always showing remission in slides. And when my dad's team eventually said, well, essentially we consider you cured. You're now past the 5-year mark. You've no relapses. You're healthy. And years later, and we don't expect this to ever come back, and said cured. Still, everyone was very apprehensive to use cured in a public setting. But every year we go to one of the events now, our LRF's events, and hear doctors speak on the main stage or the breakouts for disease-specific subtypes. Cure is used more and more and more in PowerPoints and presentations and discussions, where when we went through this, that wasn't a word anybody was ever using, and he just said it a few times. So I just want to flag it because that's for people that have lived through that, that's massive, that type of change in thinking and what the future holds.
I would say from our standpoint, technically to be cured, you have to live the rest of your life and die of something else. So it's sort of a retrospective definition. So sometimes
you have goals. You have goals now. You see, you're retired. So
but I think once there's a certain number of years,
looking for something. Yeah, so you're retired, so you're looking for something. Now you just
Well, if I may add, in 2012, I was informed I had tongue cancer, and I've gotten 2 tongue cancer surgeries since. I've gotten skin cancer since, and I've gotten a craniotomy because they thought that the tumor that was in my head, brain area, was also cancer. It turned out not to be. It was benign, thank God. But I had it in 2012. It was another awakening of other things that can still happen to you, even though you've been cured of blood cancer, other cancers can still pop up, and you have to deal with them. So
He needs some new hobbies. If anybody out there is watching, anybody out there, you feel free to type in the chat. Like if you think there's some hobbies for him or something.
I mean, yes, you become very well versed in this with all of your experience.
But the whole point is giving hope to people, and that's why I hope this program tells people that there's so much better hope today than there was in the past.
And one of the reasons I think for that, and you mentioned your appreciation for R&D, for research and development
better
there,
believe it, yeah.
and your participation in the clinical trials. So, Doctor, can you talk a little bit about how important those are to treating and the furthering of new treatments for?
I mean, it's really how we move the field forward and how we do better. You know, every year, every couple of years, we have better therapies. So there's a lot of different new approaches. As we understand more about diseases, we and others think of ways to attack those diseases, and sometimes those are medications. In rare diseases like peripheral T-cell lymphoma, a lot of those ideas are borrowed from other cancers. Where it works there, we see some commonality, we apply that back. But to take it from the idea stage to knowing that it works, and then to moving it into a standard part of therapy, at some point we have to test that on people. So we try to be very careful in designing studies. We try to make sure they really have a strong therapeutic intent, meaning the goal is to get you better, not just to learn, though we really want to learn. You apply those to patients, you see when they work, you try to understand when they don't work, why they don't work, and then that falls back on itself, and then you build better regimens that way. And that's a not fast enough process, but there's no other way to do it than patients participating. So a clinical trial is always a very personal choice because you're putting your health or your life in the hands of the trial, but through what's usually a very long discussion and talking about what the alternatives are, you know, it's a good option for many people, maybe not everybody.
So let's go to Rich then for a second first and talk about your personal experience with it and why you wanted to participate. I know you touched a little bit on it earlier.
Well, there wasn't a standard treatment, so I said to myself, okay, let's try something that at least I have a better chance of survival, number one, and whatever is learned in that clinical trial can help others in the future when you think about it. And when I came out the other end, and I have things to talk about while I was going through it, but when you come out the other end, the doctors did find that the monoclonal antibody that I was using is something that they don't want to do again because of its toxicity and the side effects that it gave me. It gave me peripheral neuropathy, which is going to be with me the rest of my life, which is a tingling on the bottom of your feet, and it doesn't go away. There's no cure for it, but I lived. And so the doctors have learned that the research did prove something. It proved that it can save someone's life. It did in my case. I'm one of 2 survivors. But at the same time, it gave them an insight to say, we're not going to use that particular other medicine besides the chemo in the regimen. So that helped everybody. But at the front end, I had to be approved for the clinical research. And if you want, I'll tell you more about that.
In one second, so because Chris, I see you want to get in there.
Well, I was just going to say, and also the doctors we saw, because we made sure to get to experts in this field, they all said if it was us and we had this cancer, we would go into clinical trial too. They were very strong in saying that's your best chance of survival.
So was this an easy decision for your family at the time to decide to go into the clinical trial?
Well, I got all the data points from my son and my wife and myself, and I put it all together. And again, my background helped me to understand you got to just take the bull by the horns and do it. Yeah. And that's what I did, and it worked out fine for me, you know, and that's what I'm happy about. But you had to meet criteria too to get into the clinical trial. You had to be a person that didn't take any medicines up to that point. Thank God I didn't. And you had a...
You're talking about chemotherapy type treatments,
chemotherapy.
Not like, other methods.
I mean, that plus you had to get paperwork done. You had to sign agreements with the clinical research. You had to get your will, your power of attorney, your advanced directives all in order. All that had to be done. You had to go to a cardiologist to get what they call a Muga test. Back then, they don't do that anymore. But it was a to test your heart, whether or not it can withstand, in my case, 650 hours of chemo that I got.
Wow.
I went through 6 cycles. Each cycle started on a Thursday, ended on a Tuesday, and I was totally connected to the infusion throughout that whole period. But we found ways, and Chris will tell you about that, found ways to take that whole experience and make fun out of it by doing things that he developed throughout that. And by the way, for the audience, you need to also take into account there's going to be a lot of relatives asking and friends asking, how are you? How's things going? They couldn't answer all the emails. He put a blog together so that everybody could tie into one blog, and he gave all the updates.
So why don't we bring you in now, Chris? What were some of the fun things, or how did you deal with going through it? I mean, I say fun with the quotation marks around it.
I have a last question.
Absolutely.
If somebody had PTCL now, and not otherwise specified, which he had, would you still say that their best, like a clinical trial would still be a better thing, or is it now closer versus standard effective, or
I think there's clinical trials and there's clinical trials. So the clinical trial that you run used a strong combination of chemotherapy.
Right.
I would say that recipe may not be standard, but that concept is standard. And then they added an antibody onto it from what you showed me from what they did. So there's clinical trials where we take a standard regimen of chemotherapy that we know could cure some people. We wish it would cure more. And then you add a drug or two, or you add something to that. And we call it, it's like standard of therapy plus. Okay. And to me, that's one group of clinical trials. Then there's other clinical trials that are testing a whole new concept, like we're giving a very different medicine that works in a different way that we don't know what the long-term experience is. So they're kind of different decisions. So when we see someone with a new diagnosis, we do have studies that are giving what we think is a relatively standard chemotherapy regimen conceptually, and then we may be adding medicines to that backbone. So there are, for the strong CD30 expressing T-cell lymphomas, there is more of a standard off of study with a drug targeting CD30 plus chemotherapy that did quite well. So that would be more of a standard that you might get anywhere. But then for NOS, we might do a clinical trial trying to build upon that.
which means more choices then, I guess, now.
More choices, so there's standard, there's different standard options, and then new ways of additionally targeting the lymphoma from what we've learned.
So then while we're on that there, Doctor, just since we touched on it earlier about what Rich needed to do to qualify for that particular study that he was a part of, is that still pretty much the standard, or has that changed in terms of what you need to qualify for these studies?
Yeah, I mean, some of that seems maybe more than we would do. You try to make your studies treat real patients, so you don't want, you don't have to like run a mile in 4:20, jump over a big ditch, climb up a rope. It's
all of which he did at the time. At 65.
I mean, we don't want to only treat trained athletes.
Navy SEAL type test.
But a lot of times when you're looking for a new regimen, what you're trying to do is see if it works better. And if someone has obvious underlying problems that's going to make the chemotherapy or the treatment hard for them to tolerate, you may not be really getting at the sense of, does this work better? You think this person's not going to tolerate this treatment, and therefore they're not going to get it the way you plan to give it, and it'll be harder to assess. So some of that still goes on, though I think more and more in terms of what we call comorbidities or other illnesses, trials now try to treat what we think of as more real patient population. Most people who have this are in their 50s, 60s, or 70s, and they have whatever happens to you in life by the time you're 50, 60, or 70. If we're trying a treatment of untreated patients or new diagnoses, we often will require that you've not had any prior therapy. But more and more, because we know that people with peripheral T-cell lymphoma may have aggressive disease, and they may start on some treatment before you get to the center that has a study, when possible, we'll often allow one cycle of standard treatment and then still allow you on it. So that's an attempt to, include people who might have fast-growing disease and couldn't wait to get a second or third opinion at the center where the trial is available. And that's probably done more often now than it was back when you first started.
How long did you wait from the diagnosis to participating in the trial back then?
Treatment in May. My symptoms were the previous November, December, and from December through May, we were seeing doctors, getting biopsies, and being evaluated, trying to get everything. So it was a long period
almost
of time.
a year, it sounds like.
Well, it was March, April, May was from February, March, April, May were kind of the, we know this is cancer now. Now what type is it? What are our options?
And then from there to the actual clinical trial.
That was pretty quick, I think. I have to go back and look, but within a few weeks it was just kind of, we know this is aggressive. We know we have to deal with it. We've been waiting long enough already. He's getting sicker and sicker, and
So it wasn't that you had to wait that long before, so that
Oh
you
no, they were
had
ready to
standard
take us. They,
care. Okay.
because it's so rare. They'd been 5 years into the trial, and I think he was patient number 27 or something along those lines, where they were trying to recruit people from this across the whole country. So when they saw that, they're like, "Whenever you're ready to come in, we can start you now."
Yeah. So let's go back for a second then, because Richie talked about how grueling it was, going through those chemotherapy treatments and how long you were connected there. But you had some fun dealing with the stress of the situation. And
Well, the first cycle was the toughest in the sense that the first night that I was given the monoclonal antibody, my whole body went into a super chill state and then a very warm state. It just fluctuated really dramatically.
Is that the fun part?
That was you weren't there. My wife and my son were not there at the time, thank God, because it was scary to me knowing what was going on here. But after that first cycle, things calmed down. Anytime I received that biologic medicine, it was easier to take. But then when you could take the cart with your infusion, walk around the facility. This was Building 10 at NIH. They had a big thing about that on TV recently. First in Human, it was a great exposition of what goes on in that building. But I walk around. I actually went with my fanny pack. They actually gave you a fanny pack with a motor in it, with the chemo in it, and I could walk around the whole building. And I went to see the doctor that gave the pathology report that said I had what I had, and she was in the bowels of this large federal institution of trying to find her. But I knew my way around the government, so it was kind of pretty easy to find how they handle that stuff. But you could walk around and do stuff, and then Chris, I'm going to let him tell you about the experiences outside of the facility. But before I do that, each of the cycles.
That's a tease. That's a tease in the business right there.
And we'll be back in just a few moments. No.
But for each cycle, he would bring a wig in for me, and the wigs ranged from Edward Scissorhand to whatever, you name them all. He'll name them all. And we teased the staff. The doctors were wearing them. We got pictures with the doctors, and it made fun not only for me and for my family, but the staff. They got humor from it, and they laughed, because laughing was, to me, a very important integral part of getting better. You had to laugh at things as they were. You couldn't change them. You just.
It's a shame Chris isn't funny.
He's funny. Oh, he's funny.
Anybody has ideas
This guy
on?
he's gonna be, he minors in stand-up comedy, I guess.
I'll let him explain what he.
Was that the third time? He's like, I'll let him tell you.
Yeah,
so
go
I
ahead.
wore these wigs, and I.
So go ahead, Chris. So tell me about the wigs there. Edward Scissorhands.
Okay, yeah. So he didn't want to wear the wigs at all. Let's be clear about this. He hated the idea. We'd beg him. So I had you ever seen those Rastafarian ones you can get when you're on a cruise or whatever? All the the little Rastafari with the dreadlocks in it. Yep. So I ended up. I had one of those from a Halloween or something. Ended up begging him, like, come on, wear it. No, people aren't going to find it funny. Wore it, and we were driving into the garage, and you have to get the ticket, and the person checking our car started laughing. They look over and see him with dreadlocks, and he's like, "Oh, this is great!" So he kept it on the whole day through the whole admission day. So you go to the clinic, you get blood work, you get CT, you get all this stuff. Then you go up to the clinic, then you're waiting in the waiting room, and you go in, then you get a PICC line put in, then he would go down. So he'd wear this the whole day around the whole facility.
3 cycle.
And they're like, okay. So I went online and got there was a blonde, this huge afro for him. Got an Edward Scissorhands one, Japanese samurai. With the bun, a surfer dude, like a blonde surfer wig with seashells on it, like a necklace he wore. So he had a different thing every cycle, and he would wear it the entire day then. Then it became a thing. But it did bring a lot of happiness and smiles to everybody, because then the nurses would want to wear it. The doctor, we had pictures with the doctors, with the technicians, with nurse. I mean, all the people that kind of interacted with him throughout the day. And it was fun, made people laugh, and then I think one of the times in the first few cycles, it's not as bad. I mean, it starts to become cumulative, but the first few cycles, we were able to do some fun things, like the fanny pack. I think it was cycle 2, actually brought him up to New York, took a Amtrak up in the morning, came up, saw August Osage County matinee, and had a bite to eat, and then hopped on the train and went back home. Went to see some shows and stuff in the DC area with his little fanny pack on when the first several cycles. So we tried to do fun things, and I remember going home. I think it was the first cycle. I made a detour and brought him to Build-A-Bear, and and it was. You can imagine him at a Build-A-Bear. Fortunately, there was like a wife and a son there, so it didn't feel like this weirdo walking into Build-A-Bear. And he made like a little dog, which was like our dog. Our dog. May she rest in peace. That he made like a little dog to remember Penny. But there was like a Girl Scout troop like outing that afternoon there, so it's all these kids like making their bears, and then him.
I hope you got a picture.
Oh yeah, we have plenty of pictures.
Good.
Let's roll the picture now. But we did that. So you bring that with him to the cycles, because Mom and I would be there with him each day, but we would go home at night, and so he had some stuff there, some creature comforts, because he'd be there for 5 days in the hospital. So we just fun things like that. And we did have a blog, so we could share all the videos. We'd do video updates from him to all our family and friends.
That's why he's so good in front of the camera.
Oh yeah, we do. It was one thing. 4th of July, he'd always have fun hats on and do different things to kind of update the family as we went through the journey. And we had an email list we'd send out to people just so we could update everybody at once around the world. And just used a lot of technology too throughout it. One thing we did throughout the process. This is not a fun thing, but something that I mentioned it to a lot of friends who have gone through cancer, or reach out. They're like, hey, can you help me get to whoever, or what should I do? And without fail, usually a lot of them are like, oh wow, I never thought about that. We also recorded all the doctor's visits every time we went to every cycle. With permission, we would say, hey, can we record this? Because you're getting so many things coming at you at once, and you're kind of in shock as you're hearing all this information, especially for the patient, but also, wait, did they say...
So it's for your own memory.
For us, to go back, but that helped us in our decision making too, and they said, wait, is it going to be... Did he say it was 6 cycles of this, or coming on a Thursday? What did he like? Did they say the prognosis is that you could go back and hear exactly what the doctor said? But also, the Lymphoma Research Foundation. I'll make a plug. They have this awesome app. We were part of the people when they first launched it. What do you need as patients and caregivers to put into it? There's a recording capability built into it. You can track your meds. You can do all these things built into it. Of course, now you can record on your smartphones and do things like that too. But so we used as much technology and tools as we could to kind of lighten our load and to leverage throughout the whole process. But humor was a huge part of it.
Yeah, I made a request on the mobile app that LRF put out. Please put in there a dictionary of terms, because I was having problems understanding all these terms, and if there was a place where people could go to and naturally understand what lymphocytes are, and I thought they were bugs. And, what do you do?
It's not the urban dictionary of terms. It's just the dictionary of terms.
You needed something, and it's helped so many people I've talked to about that. But one thing that Chris didn't bring up was, because he's very apt in the world of the internet, he put out a request for his dad to be put on a prayer list in every continent in the world. And people wrote emails back to him saying, you're on our prayer list. I'm a big believer in prayer and how it helped me through this, because at the front end, when I first found out I had it, I went to my church and I got blessings from the priest, and that helped me calm everything internally, that I was at peace with God, and that was really important during that time.
So, Doctor, I want to touch on a couple of things that they just talked about. First of all,
how important are wigs?
Essentially, yes. How important is that? Whether it's, we're talking about wigs, but laughter or prayer or just having that community when it comes to dealing with cancer.
I think it's tremendously important to have a good attitude about things, to sort of take the positives that you can. I think it helps you get through the process. Do we have data that people who laugh do better than people who don't laugh? I don't think we'll ever have that data, but it makes the experience more tolerable, because in addition to what happens long term when we're trying to get rid of this lymphoma, is you have to survive and get through the treatment, which the treatment we went through was quite hard. So I think it really does help to have a good attitude, a good support system. And I think all those things really sort of speak to the idea that you really brought a community of people together to support you through that, to give you the best chance that you had with whatever the outcome was going to be, that you get through that well. And then, to a certain extent, the future is the future. But it sounds like you guys really did a fantastic job of pulling together tremendous support to get through that, and helping the staff too.
I wanted to say one more thing too. Is we had gone to a musical in Virginia, and Cheetah Rivera, who is part of the original cast of West Side Story, she was there, and Chris says, "Look, go over and get her signature on the bill, on the playbill." I went over and talked to her, and I said, "Cheetah," like we were best friends, right? Yeah, right. I said, "Cheetah, right now, we're talking, I am receiving chemo." She says, "What? Oh, are you kidding me?" I said, "No." I said, "Here, see this line? Goes to this bag, and this bag has a motor and chemo in it, and I watched your whole performance here on the stage today, and I'm getting chemo while I'm watching you." So it helped her to realize that it's possible, and it's also helped me to get the heck out of the hospital for a weekend, just on a Saturday or Sunday evening, just to enjoy something different.
And you also got a kiss from her too. So we have a
did.
picture of
I did.
Cheetah Rivera giving him a kiss on the cheek. That was his, yeah.
You miss 100% of the shots you don't take in life.
Right.
But that's another thing, Doctor. So, I mean, we're talking about getting on Amtrak trains, going to Broadway shows. Can patients today with PTCL, are they able to continue living their lives?
Yeah, I mean, if you feel well enough through the treatment, that treatment that you got, if we gave that here, we give it as an outpatient. So you come in, so that's the standard now here. You come in, you get your bagged up, you go home, do whatever it is you do. I mean, don't go swimming in a lake, but anything else within reason, come back the next day, get the bag hooked up, go home. So often we'll do that treatment as an outpatient, and people are able to do that. We would like you to be as much time being yourself and as little time being a patient as possible. I think the nature of the treatments are that you can't totally not be a patient, but certainly more and more you can do that. And in addition to new therapies that work better, sometimes we have new therapies that work the same, but they're less toxic, they're oral, they take less toll on your body, and things like that.
Right.
It just allows you to just have better quality of life while you go through this experience.
And we also heard Rich talk about the glossary of terms, right?
Yeah.
There's so many things that patients go into their doctor and they're unfamiliar with there. So what questions do patients with PTCL need to be asking their doctors when they're going in?
I think you want to make sure that you understand the diagnosis as specifically as possible. I think the good of the internet is that you have access to almost unlimited amounts of information, and that's also the bad. And these terms overlap, and once you get into a T-cell lymphoma, you may start reading about things that have little to apply to you. So I think you should try to understand your diagnosis specifically, write it down, so you can filter things you hear. That's a different kind of lymphoma, that doesn't apply to me, or that does. I think you want to talk about treatment, you want to talk about treatment options, and understand not just the words we say, but what that means to you. Mm-hmm. I find things like prognosis is very different and very individual when people say what's the prognosis, what they actually mean by that. So I think you want to try to ask your questions as specifically as possible so you get the information you want and you don't get a lot of numbers or information that maybe you weren't exactly asking.
Can you give an example of that, like two different types of how somebody might ask for a prognosis?
Yeah, so what's my prognosis might mean that how am I going to feel over the next 3 months of chemotherapy. It might mean what's the chance that I'm going to be alive in 5 years. Mm-hmm. And those are two very different answers that a doctor might hear in prognosis. So often we'll respond, well, what do you mean by that? What information do you really want? Mm-hmm. So we can give you the information you want and maybe not give you a bunch of information that you don't want.
At the time, the doctor just mentioned going on the internet now with PTCL and seeing what you find might not apply to you. Is that what you did? Obviously, Chris, I know you are internet savvy, shall we say. But were you going
he's got a
internet?
Facebook too, okay? So we're going to launch TikTok soon. With him. I'll tell you about my TikTok later.
Oh, boy. So were you going to the internet as well when you got home to look up some of these things, and how did you find the information you were getting there?
Yeah, I don't remember exactly what websites we found at the time. I'm sure the main cancer societies and organizations that be out there, just in general stuff about this type of cancer, peripheral T-cell. There weren't as many subtypes back then, so it was more of a broader, hey, 1 out of 5 are going to make it, and it was just kind of a gloom. It wasn't a happy picture. Of course, you can have a cut on your finger and go hit the internet and then feel like you're going to die by tomorrow. So I think there's so many things you read on the internet and you go to a doctor and they're like, hey, it's not that, or it's not that bad. So, but everything we found out about it when we heard about it was we're dealing with something very serious. And then we just relied on experts talking with them in person to.
So then, at what point
move
did
forward.
you find the Lymphoma Research Foundation in this process, and was that a regular source of information for you moving forward after that?
I believe I found that one by just doing some searches. I was at home recuperating from all this after 6 cycles, and I found that there was an organization called Lymphoma Research Foundation. I made a phone call to them and started a dialogue. But in the meantime, I had also gotten a call. I don't know how it came to me, but came to me from England. They were curious as to what I had gone through with peripheral T-cell lymphoma here in the States, and they had some reason for calling. I gave them the information that I had went through, and it was kind of interesting. I haven't heard from them since, but I've been dealing with LRF now for 9 years, and they've been the organization to go to for educational material, for helpline, for literature that you need for various things. And the thing that I tell most people when I meet with them is, if they haven't found a doctor, the Scientific Advisory Board is a total list of all the best doctors in this country that know anything about lymphomas. And then call up the helpline, have them help you find one of those doctors nearest you that are either on the current list or previous list who can help you with your lymphoma, and that's very important. I did want to add one other thing about coming out of that whole experience. Something wasn't mentioned back then, and that was chemo brain. When you get all that large quantity of chemo coming into your body, it does affect your brain thinking abilities at the time. It does reconstitute itself, but it's something they never talked to me about, the doctors, for some reason. I also obviously had lots of fatigue. That's normal, and then peripheral neuropathy because of one of the chemos. It has historically been one to initiate peripheral neuropathy, just like they have for people with diabetic conditions, but it's a similar thing.
He was also, early on though, how we ended up becoming eventually ambassadors and getting more involved. There's a pen pal program essentially with Lymphoma Research Foundation where you can partner up with other people out there that have gone through this and be connected with it. So he had volunteered with that to help other patients around the country that wanted to talk with someone that's dealing with this type of illness, who's gone through it already, to help. And he's done it with multiple people, and I've done it with a few people too, where you can be partnered up with somebody. So that was kind of a way that got involved more with the Lymphoma Research Foundation. And of course, when they launched this ambassador program and said, hey, would you guys like to be involved on a greater scale?
Why was that so important to your family to participate in a program like that, whether it's the pen pal program or the ambassador program at
I think it's giving back and how I was raised as a young kid here in Brooklyn, New York. I'll take credit for that and thank my parents, really. They're the ones that instilled that in me, and giving back or helping others was something we just learned in school.
Well, in the first connections, like when you connect with these other people, for me, because I represent caregivers in the ambassador program, there are so many things that I've discovered that I just figured out along the way about how to manage this, how to be a great advocate. Even if you're dealing with the best doctor and the best facility in the world, you still have to be the one asking the questions and making those appointments and really just staying on top of everything and realize, oh wait, they said upstairs we were going to scan this part of his body. Well, that's not what the orders say. We'll call up. Oh yeah, they typed the thing in wrong. Like just these little things that, just because you're dealing with humans, just to be on top of, but how we managed it and the recordings and the Google Calendar and how we laid out all these little things and tips about how we went through the process. There are so many other people out there that are dealing with this for the first time that don't know what they don't know. So the opportunity to help them, it's very rewarding, but also to just shortcut all that extra expended energy they don't have to expend when they need to really be focused on their loved one or their patient, rather than trying to figure out all these other little details. And now I've seen it's kind of become a templated type thing where I have family and friends and tons of people I know that have this illness or that cancer that email me, and now I was like, okay, do this and this and this and this and this, and here's your comprehensive cancer center in the area, here's the list of here to find them, here's this doctor, call this helpline, do this, and they're like, oh, okay. And there's so many amazing resources out there to make your life so much easier and make the process so much smoother that people just don't know it, that they exist, or don't know that they're out there for. So it's rewarding to be able to help people and see the little bit of relief and give them a little bit of, encouragement and hope.
Do you wish you guys had a program like this when you were going through it? Be it the Ambassador program or the Pen Pal program? Or did you?
Yeah, it would have helped me understand it, but then again, my mind at the time going through the disease, the blood cancer, the only thing is you're thinking is survival. But for my son and wife, I'm sure that they would have loved to have had something like that.
Well, Mom and I were such a great support network, and and the fact that we were willing to talk about it and share it with other people, we had support coming from family and friends and neighbors and loved ones in the church and the community and business associates of mine. So because we were willing to share it with other people, we had tons of support already. I liked taking charge and figuring out what was going on and kind of being in charge of stuff. If there were other resources that I had found or said, this is what you should do, or here's an info sheet on this type of cancer, which now that all these things exist, and so are so much more accessible. Definitely would have read it. We plugged into everything we could, read everything we could. I bought books. We were just listening to podcasts back then, but listening to audiobooks and
we'll get to that plug later on.
No, but there weren't podcasts back then for this type of stuff.
No.
So we were just we were going in, getting everything we could at the time. Now there's a lot more out there that we could turn to and get that support to help give us the jump start that we're giving people now.
Right. Doctor, I want to come back for a second because obviously we talked about the word cure and we're hearing about Rich's process after he went through the clinical trials and his treatment. But what happens with PTCL if somebody does relapse at this point?
So if it does come back, then you weren't cured by your initial therapy, and that's emotionally hard. It can be physically hard. You can get sick again. Most people are being monitored, so it doesn't usually take weeks and weeks and weeks and weeks to figure it out. Usually you're clued into that. And then there's a lot of individual choices. There is a chance to get rid of it permanently a second time. That involves getting back into remission with other therapy and then getting a bone marrow transplant from another person. That's a very intensive, very high-risk procedure. It's not the right thing for everyone, but it's the right thing for some people. And then there's a whole bunch of new medications that are being studied. Often with a new medicine or a new approach, we'll first study it in people who haven't been cured by the initial therapy, thinking if the initial therapy cures you, we know how that works. You do that, but if it doesn't, and there's a number of new drugs that target different parts of things going on inside the tumor cells, immune therapies, which have revolutionized cancer care in other areas, have been largely through activating good T cells to fight cancer. So it's been a little harder to apply that to T cell lymphomas, where some of the T cells are the cancer themselves, a more complicated problem, but some of those treatments are now coming into clinical trials. So you have this a lot of choices, not a clear best way to go there, but again, it's sitting down with your doctor, thinking about what's available, thinking about the goal. Are you moving towards a bone marrow transplant or something very aggressive like that, or are we looking at other treatments to try to get it better, but maybe maintain the disease better without really getting rid of it?
And right now, looking to the future of PTCL, what has you excited about the treatment possibilities moving forward?
Yeah, I think our understanding is increasing, and matching that understanding to therapies that target those abnormalities in the cells, I think that's increasing pretty quickly. So there's a lot new therapies that are good ideas that are being applied. What gets more complicated at that point is you start learning about differences not just within the different types of T-cell lymphoma, but even within one type of T-cell lymphoma. Different cells may grow or through different mechanisms or may be vulnerable to different medicines. So that's a lot of work teasing all that out, but there's a ton of opportunity there. And then really starting to move some of the immune system therapies into treatment for T-cell lymphoma, because we're very early in that stage. But that has the possibility also to really take some of these lymphomas that were not otherwise being cured and really put them at least into long remissions.
So we've heard a little bit about where we've come in the last decade when it comes to Rich's experience going through there. What do you see as the next decade for lymphoma and PTCL?
Yeah, what is it? Predictions are hard predicting
Yes.
about the future. So I think there's a lot that we're doing, and I think things will continue to get incrementally better. When you study a new medicine and you see some promise, you don't know whether that medicine is going to fundamentally revolutionize how we treat that group of diseases, or whether it's going to be a little bit better or a little less toxic than the last treatment. So there's a lot of those efforts going on. So I think we're going to continue to have incremental improvements. And if I had to guess, 10 years is a long time medically. There will be pockets and subtypes of T-cell lymphomas where probably something will be understood understood, or one of these new therapies will make a huge improvement, but it's probably going to be multiple different solutions to multiple different types of lymphoma.
Hearing this for both of you, I'm very curious, just based on where you came from in your treatment and your family's experience, hearing where we are today, how does that make you feel?
Extremely excited for the next generation, period, for knowing that others can be helped with this. I know I've been helped with something that probably most people never heard of. I take a cancer drug for B-cell lymphoma, totally different than what I'm talking about here. But for my rheumatoid arthritis, I get every 6 months I get a medication called rituximab for my rheumatoid arthritis, which is an outgrowth of what has happened in this whole blood cancer community, is developing immune suppression medications that are multi-used, in my case for rheumatoid. So I look forward to the next generation really benefiting from, the clinical research and all the new medications that are coming out from what the doctor is doing and other doctors and researchers are doing around the country.
So with that being said, what would you say to a newly diagnosed lymphoma patient today?
Have a lot of hope, because that's what this is all about. When I first got not only the cancer but my rheumatoid, the thing I was looking for the most with any meeting with the doctor was, what's coming down the pike, doctor, that gives me hope, because it helped me go to the next stage and anticipate that I will be cured. And in my case, with this, I was cured.
And Chris, for you, for the families out there, if there's someone newly diagnosed, what would you tell the caregivers?
To be afraid of asking for help or sharing your experience and your journey with other people and leaning on other people. It's amazing how many people want to support you and help you. And even if there's not a lot of people locally that you can reach out to, you can reach out to support groups in your area, or you can reach out to support groups online. You can definitely plug into the Lymphoma Research Foundation. Obviously, you're here, so you're in their orbit hopefully already, but you can reach out to that organization and be plugged into people you can talk with directly, helplines. You can get a lot of help that way. But I think just not being afraid to ask for help along the way, or even the medical community and the social workers, the doctors and the nurses saying, look, we are having problems with this or that, or don't know how to deal with this, because there are a lot of emotional and psychological things that happen throughout this journey too, that you're dealing with, not just the what medicine do I get next, but how do I deal with what's going to come with all of that, or what's behind door number 2 or door number 3 or whatever that uncertainty of the future. So I don't think there's anything to be afraid about sharing it with other people and talking about it. But you asked about how does what he said about the future inspire us? And I think back to what I talked about just over the last 10 years with hearing them talking about cures and these new medications. And every year when we go to the Ed Forum, we hear new breakthroughs and new treatments and new slides, and it seems to be accelerating. Whether it's not, of course, at the speed anybody would want it to be, but it is accelerating from where we were over a decade ago to where we are now. And hearing that amount of hope and being and news and being plugged into all of that is just still provides us hope and brings tears to my eyes when I hear some of these things, because it's so inspiring. So I think staying plugged into what's out there too, and not isolating yourself is probably the big umbrella thing is opening yourself up to everything that's out there.
I appreciate it. Chris, Rich, Dr. Horowitz, thank you so much for taking the time today.
Thank you, Joe.
You mentioned
Thank you,
sharing.
Joe.
I want to tell everybody out there that Rich also shared his story on the Living with Lymphoma podcast, which you can check out. His episode features LRF Scientific Advisory Board member Dr. Kieran Dunleavy of GW Cancer Center, who was also part of Rich's healthcare team at the time. And as you mentioned earlier, Chris, there you can find plenty more information at lymphoma.org/PTCL for more on peripheral T-cell lymphoma, and then the LRF helpline, which is a great resource out there. You can call 800-500-9976. One more time, 800-500-9976. 9976 for more information. For our esteemed panel today, thank you so much.
Also
for,
doctors
yes.
that are saving lives like my dad,
There
so
you go.
thank you.
Thank you.
Thank you so
Thank
much,
you.
all of you, for taking the time, and thank you so much for tuning in.